Anyone wishing to ask a question, just please come up and I will hand you the microphone. Questions for our speakers? You gotta come up here. Bring him up. I'm like the microphone stand.
There he is, Mike Oshner. You, the one. Okay. All right, you were talking, awesome presentation. At the end, I love the fact that NAD was restoring a lot of these things. But back in the Skin 1 models with the NRF2, you were, with the Parkinson's gene, you were finding enhanced mercury levels in the organisms and depleted expression of NRF2. And you were talking about NRF2 in the context of free radical control, but you weren't talking about it in the context of mercury export from the animal, because NRF2 should turn up all the phase 2 enzymes, so you get glutathione transferase up, you get glutathione production up, and I think now they're finding the MRP2, the transporters involved in MRP2 as well. So if you have good NRF2 expression, you should be able to move more out. Or conversely, if you have poor NRF2 expression, you should be holding on to more mercury. And so one part is, have you looked at that at all?
So the question is whether in the NRF2 mutants, if we looked at the levels of mercury.
Kind of, didn't, when you were
we,
looking
we
at
have actually, they do have higher levels of mercury.
Yeah,
yes.
yeah. But when you were looking at the Parkinson's worms, you were seeing higher levels of mercury in them, and you were attributing it only to transport in. But I thought you said that they also have a depleted NRF2 expression, which would limit transport out.
Yeah, that's possible. We've not looked at it specifically, but you're absolutely right.
Yeah.
Yes.
And then the ubiquitization, or ubiquitination?
Ubiquitination.
Ubiquitination. For NRF2 to work, you have to ubiquitinate KEAP1 to release the NRF2.
No, the KEAP1 is not ubiquitinated. It's actually oxidized. It does have a number of cysteines on it.
Yeah, and that's where I always read. So you got the cysteines and you got some free radical expression that causes them to form disulfides,
right.
and
So,
that releases the NRF2.
Right.
But then the newer literature, they're talking about stabilization of the NRF2, and there's a bunch of look it up, ubiquitination of the KEAP1, that's actually necessary for the whole thing to happen. And so if the animal has problems with ubiquitination, that may be part of why NRF2 isn't working for it.
It's possible, but another thing that you have to keep in mind with the NRF2 is actually that the important part of the NRF2 is the part that's being translocated into the nucleus.
Right.
So you can find in animals, or if you use human tissue, that the levels of NRF2 actually don't change, but that the distribution of the NRF2 changes between the cytoplasm and the nucleus.
Right, and that's what makes
if
the whole thing happen.
If there's obviously changes in KEAP1 and you have more KEAP1 inside the cell because it's not getting out of the cells, it's not being degraded, that may send a message, through a feedback loop. You have less of the KEAP1 that's being synthesized, so there's a lot of other possibilities, obviously, but we've not looked at that specifically.
I had just seen the ubiquitination stuff on it a couple of months ago. So while you were talking, I looked it up quick.
Yeah, you're right.
It's totally essential for stabilizing NRF2 inside the nucleus.
Right.
Yeah. So
there's actually other transporters that are important in terms of getting the NRF2 because it's too big. It doesn't diffuse.
Yeah.
There's some specific carriers. I forget their specific names right now.
Right.
But anything that has a cysteine group on it might be susceptible to mercury, and that's always been the conundrum. Why are certain enzymes affected by mercury and others are not? And every cell should be affected by mercury, and it's not the case. Some cells are more susceptible than others.
Right.
So the question becomes, is it related to levels of glutathione in the cell? Because we know in neurons, for example, the levels of glutathione are much, much lower than in astrocytes, which are sort of the Rodney Dangerfields of the brain. They're still looking for respect. But they're important in terms of, they're sort of liver cells that have lost their way and found their way into the brain.
Oh.
But they're like the garbage disposals. So they can resist actually mercury to a much greater extent than the neurons, because they have millimolar concentrations of glutathione.
Right.
Whereas the neurons are in the micromolar. So
that's why neurons are so susceptible.
That's why neurons are much
levels.
more susceptible. But then smaller neurons seem to be much more susceptible than bigger neurons. The molecular granular cells, for example, in the cerebellum are much more sensitive than bigger cells, like Purkinje cells. If you dose an animal, the smaller cells tend to die. And there's a lot of theories about that. We can go into that. We don't know why, because theoretically, everything that has an SH group on it should be affected by the mercury.
Right, right. Thanks for your work.
Thank you.
Hi, thank you. Mary Ellen, do they have a program for dental functional medicine? Is there a route to that at this point, or a degree?
I can only, yeah, I can speak to my route. I started with, basically I went to, how I got there is I was hit by an 18-wheel truck 20 years ago and couldn't practice for a few years. And after that, it was functional medicine that got me better. And so I was hit, I was hit by an 18-wheel truck when I was 8 months pregnant with my second daughter, and got very ill as a result of, and was out of practice for about 4 years, and came back because of functional medicine. So when I was able to get back to practice, I was at metagenic seminars. I was doing it was the early days. I was fortunate enough that one of my primary care providers was an early student of Jeff Bland. And so I did the nutraceutical, I'd be the only dentist in the room sort of thing. And then when Metagenics would have Jeff Bland's seminars, once a year he would get up and speak, and it was February 2007. And when I could understand 75% of what he had to say, I figured I was, or it was February 2008, I figured I was ready. I took Applied Functional Medicine in Clinical Practice. It's a week-long seminar. But to go right into that, you really need to review your anatomy and physiology. Phil Malika and I are actually looking at developing a 2.5-day class for dentists, just to get them to the point where we can sit at an AFMCP and not be blown away. Chris, the only reason I survived detox was because of what you taught us in the NMD program about liver detoxification. Liver detoxification never made sense to me until your lectures. So there's some really good people who are teaching pieces of that. So to the degree that you can get yourself fluent with the language. So I did the AFMCP for a week, and I think it's a great introduction. It gives you a good overview. What IFM does have right now for people who don't want to make that commitment is they now, if you go to the website, they have one-day seminars. They're putting on a series of one-day seminars this fall. I know there's going to be one in Santa Monica. Someone here talked to me about the fact that they were going to go to one. So I did that, then took Phil's naturopathic program, and that provided the basis. I was never going to do the full certification. I did all 6 certification modules. There are 2 of us dentists nationwide that are certified. But it was because of Chris and Phil and Bob. Because I had that base, because there were physicians in there struggling with that information. And yeah, Tufts is a good school. We learn a lot of basic medicine, but it was hard, but it was so rewarding. And I don't know, I will stop proselytizing, but it's made it fun to practice again, because I'm coming from a different perspective. It isn't about fixing teeth.
Dr. Goodrich, this is for yourself. So you impressed me a lot with your knowledge of DNA, and I'm just wondering if you could give us maybe your sense of scalar waves. And DNA, has been, as of late, kind of considered potentially a transmitter, receiver, and a storage capacity for magnetic scalar waves. Are you able to speak to that maybe a bit?
Unfortunately, I am not. Sorry, I haven't really learned anything about that.
Okay, fair enough. What about protective supplementation that you've kind of run across for that specific work you've been doing? What do you think might be something helpful for us to know?
Oh, definitely. So with regards to epigenetic research, of course, there's a lot of research done looking at the potentially harmful changes from toxicants, but there's almost just as much research looking at nutrients and different diets and things like that and how they're influencing the epigenome. So at least in rodent studies, there are several different nutrients, genistein, sometimes some of the vitamin Bs, choline, that have been tested. They're given as a supplement in addition to a chemical exposure. And then when they're given together, a lot of times the epigenetic change that you see from the chemical exposure alone doesn't happen. So it basically counteracts it. But in human populations, this has been a little bit more complex. There are some kind of theories, like for instance, some populations in Japan and China, places like that, where they eat a lot of soy, so they have a lot of genistein. They have lower incidences of cancer and different things like that. And so people are starting to hypothesize that this may be because of the impact of those nutrients on the epigenome and various other mechanisms. But I think the epidemiology there is still in development. Kind of in some studies you see this positive effect, in some studies it's a little more unclear. But there are definitely many nutrients out there that we think can positively impact the epigenome, whereas chemicals may be harming it. But we're just still in the process of figuring out what genes are being affected, what levels are good, what sources, and things like that. But yeah, nutrients, especially maternal nutrient intake too, could have a great impact on the offspring's epigenome.
I just want to follow up on that. That's real big in healthcare now, and this kind of healthcare is the idea of methylation in the methylfolate cycle. And so people are taking all these methyl donors when they perceive themselves to be low methylators. It'll be methylcobalamin, methyl tetrahydrofolate, trimethylglycine, and these feed into the methylation cycle. And then, some people ask me, is there a danger there of methylating genes? And then a lot of people conflate methylation of DNA with these other methyl cycles. And I would generally say, no, because that would be a real problem if we started hypermethylating everything because we're taking methyl donors. And then you show the data on the genistein affecting methylation of that gene. And you labeled it a methyl donor. Now, is it just clearly a methyl donor, or does it maybe have effect right on the DNA methyltransferase or transcription of the gene for the DNA methyltransferase? Do you have any speculation on that?
So I think the thing with genistein was that it more so, it wasn't a donor, it more so indirectly impacted the 1-carbon metabolism, or the pathway that you're talking about. So there are, you can look at that pathway in a simple way and say, this is the donor, these are the 2-3 enzymes involved, but really if you put up the whole complex pathway, it's several pathways working together that ultimately lead to your balance of how many methyl donors you have.
Otherwise it would be reckless methylation of your genome.
Right, and so the availability of methyl donors is important. It's one of the factors contributing to DNA methylation, but there's a lot more regulation than just that. So it's not it's something that can be helpful or potentially harmful if you have too much, like you said, but there's other regulation on top of that comes into play.
Keeps it from getting out of hand.
This question's for Dr. Levy.
Had a question if you have an opinion on IV vitamin C versus a liposomal vitamin C and the efficacy, maybe comparing the two of them.
Well, with regard to IVC versus liposomal vitamin C, it's really good to think of them as being able to help in two different ways. First of all, how you give IV vitamin C has so many different parameters depending on the condition that you're treating. For example, with a cancer patient, you might give a high-dose slow infusion over the course of several hours to not only saturate the extracellular space, but keep it saturated during that period of time. Whereas for an acute infective disease, you might want to give it very rapidly, sometimes 50 grams over the course of half an hour, which not only gets it inside the cells, but also gets it inside the cells because the rapid surge of vitamin C is interpreted by the body as being glucose, and your pancreas reflexly secretes insulin, thinking it's getting a glucose challenge, and that insulin not only makes you hypoglycemic, which we've documented repeatedly, substantially hypoglycemic, it also pushes a lot of more vitamin C inside the cell. Now, for pure power of getting inside the cell in treating a chronic condition, while it's not etched in stone, liposomal C, if it's a proper liposomal preparation, I emphasize that because these homemade liposomal preparations are not liposomes, they're emulsions. They get more vitamin C absorbed into the blood, but they do nothing to deliver the vitamin C into the cell. So people like it because it's an improvement over regular vitamin C, but they misinterpret it as being liposomes, and if they don't get the effect they want, they think liposomes failed and they really never took them. Now, the liposomes are especially beneficial because they get vitamin C, and this is an important difference between it and intravenous or oral, regular, is they get it inside the cells without the consumption of energy. Okay, the liposomes can go in by reverse pinocytosis, by passing through pores. They can make their way into the endoplasmic reticulum, the mitochondria, and even the nuclei, all without the consumption of energy. Even when you give vitamin C intravenously, once the vitamin C is circulating in the blood, it has two ways of getting inside the cell. One is it passes as oxidized vitamin C, DHAA, into the cell without the consumption of energy, but obviously you have to donate energy to reduce it back to its active form inside the cell and consume energy. Or the reduced vitamin C that's circulating in the blood needs an active transport mechanism, again consuming energy to get it inside the cell. This is why we've seen almost unbelievable observations on how 4 or 5 or 6 grams of liposome encapsulated vitamin C on an acute viral syndrome, and I emphasize that particular subset, can have an equal and sometimes superior impact to 50 grams of vitamin C given intravenously, which is extremely counterintuitive and was so amazing. When I first saw this, I did what any logical person would do. I ignored it. And then after that scenario repeated several times, I figured I'd educate myself about liposomes. Now, in the dental setting, probably the thing that we're most commonly looking at is how we use vitamin C in the setting of taking out mercury, or in the setting of significant root canal extractions, which cause a good significant exposure to toxicity, or cavitation revision, which involves a lot of exposure to toxicity. For the most part, 5 grams of liposomal vitamin C orally is going to, on a practical basis, do what a 50-gram infusion will do for you in terms of protecting that patient. For mercury removal, if you have it available, the IVC is probably superior because it gives you the opportunity to have a high amount of concentration of vitamin C circulating in the blood at the time the mercury is assimilated, and the vitamin C can do a substantial amount of neutralization of the mercury before it even gets into the tissue. all that said and done, so for your sickest patients that are going to go through mercury removal, try to give them intravenous vitamin C, but give them the liposomal as well, okay? And this is the other point. There's the multi-C protocol, which is liposomal, then sodium ascorbate powder to bowel tolerance, then ascorbyl palmitate, which is fat soluble, and then intermittent intravenous infusions of vitamin C. All four of these modalities get a lot more vitamin C where you need to get it. And I can tell you as a practical point, in just about all conditions, the only time you don't see a strongly positive response of vitamin C is because you didn't get enough where it needed to go.
And this is also for the clinicians. As far as like doing the IV vitamin C, the G6PD testing on these patients, I was wondering amongst the clinicians who are doing the IV vitamin C, who's doing that, and then if so, if you're using a lab, and if you're not doing it, I guess what would be your reasoning for not doing it?
From a pure medical legal point of view, there's no good reason not to do it, okay? It gives you a little extra protection. This is not so much medical advice as observation. I've never personally run a G6PD test on anybody. However, I've never dealt with the subset of patients in which there's a significant incidence of G6PD deficiency. So maybe I've been extremely fortunate in that regard. However, when you do identify G6PD deficiency, you have to remember that what's happening with G6PD deficiency is you're getting a propensity to hemolysis because of a decreased antioxidant capacity inside the red blood cell. And to this end, and I don't have a study to show you for it, show you about it, you can just about work your way around that with almost anybody that has a G6PD deficiency by doing two things. One is giving them liposomal forms of glutathione and vitamin C that will be taken up not only by the other cells of the body, but by the red blood cells, which will increase their antioxidant capacity and make them less prone to hemolysis. And then at the same time, whereas you don't need to do this with most people, you do a staged increase. You start with 5 or 10 grams intravenously slowly, then 15, then 25, and then usually up to 50. So as a practical point, you know, there's a few dramatic reports in the literature. It's very rare, but it is a real phenomenon. And medical legally, you are best off getting the G6PD test.
I've always been taught that you put your vitamin C into sterile water. And I know some people put it into normal saline. I want to see your opinion on that.
What do you use to put the vitamin C in for intravenous vitamin C?
Intravenous vitamin C.
Intravenous, right. The only thing you really don't want to logically use based on a logical foundation is D5W, okay? That it works perfectly fine, but you got to remember what you're doing with vitamin C. You want to get it inside the cell, and giving somebody glucose at the same time is just giving them one more thing to acutely compete with the vitamin C for getting inside the cell. So it's just counterproductive. Most of the time we use sterile water. There's absolutely nothing wrong with using normal saline or lactated ringers. Both of those work fine. They do tend to give you more volume problems. A normal saline, if you have somebody who's a borderline heart failure patient or a high blood pressure patient, normal saline can give you some acute problems with elevated blood pressure or volume overload. But per se, as far as the vitamin C goes, nothing wrong with using it.
That was going to be my question, but in regards to the osmolarity, I mean, is there any, so in administering IVC in the setting that we would be, dental setting for what you'd mentioned earlier, comparing sterile water ringers like lactated ringers and sodium chloride, and because the difference is the, I guess, the potential for it to move across. So that you may have just answered that question, other than any other recommendations from the standpoint of the getting into the cells.
As long as you're, let's say, for example, with sterile water, using a 500 cc bag, and if you give at least 25 grams, you'll be fine. And any amount above that you want. I say that because you can give 500 milligram per cc vitamin C, which is as concentrated as it comes in the vial, direct IV push. Okay? So there's no such thing as too much osmolarity as a practical point. There's other things that you can run into, but the osmolarity is not one of them. So all you really need to protect against is not having enough osmolarity, which is remedied by using a minimum of 25 grams per 500 cc's, and anything above that is fine.
This question's for Dr. Levy. You talked about the root canal teeth affecting the breast, like causing breast cancer. Let's say you have like one root canal on the right side. Could that cause breast cancer on the left side? Or is it always on like the same side?
No, you can have it on either side. It will be more common on the ipsilateral side, but there's cross connections in the lymphatics, and if your unique anatomy has a crossover, and for one reason or another, one breast might be more susceptible. I mean, there's no such thing as complete symmetry in nature to toxins. You could develop it on one side even though the root canal was on the other.
This is for Dr. Levy also. Have you noticed any correlation with the root canals and prostate issues in men along those same lines?
Specifically, root canals and prostate, no, not per se. Let me clarify, though, and say that, you know, in the presentation we talked about heart disease and we talked about cancers of the head, neck, and chest. That's because that's where the toxins are going to be delivered in their highest concentration consistently the greatest percentage of the time. That said, look at Dr. Issel's work in Germany, and he saw that 97% of his advanced cancer patients, doesn't matter where the cancer was, 97% of his advanced cancer patients had root canals or other infected teeth. So across the board, a root canal can be expected to a greater or lesser degree for a number of the physical factors that we discussed. To a greater or lesser degree, it will compromise your immune function. And obviously anything that compromises your immune function in a susceptible tissue that might have other factors going on allow a cancer to develop.
I have a real quick question about the MTHFR, and you were mentioning with the nitrous. And as far as potential of causing depression, I mean, I've heard nitrous can decrease vitamin B levels in the body, but I've never heard depression. And the mechanism of that, if you know it, and how long the depression lasts. I mean, is it permanent? I mean, can they have nitrous once and you don't have to worry about it? You know, because I don't know how many patients would be willing to go get an MTHFR test because they want their happy gas. So
Yeah, I will direct you for the specifics on that to Ben Lind. The mechanism is the methylation cycle. I mean, neurotransmitters are one of the offshoots of the folic acid cycle. It's up at the top, as I agree. I experienced it with a close friend of mine years ago. She had dental hygiene, and her family, there's been a history of depression with Zoloft, and so when I heard Ben talk about that in a seminar that I attended in Seattle about 18 months ago, it really resonated with me because she was that they're administering nitrous on each other, and she ended up with clinical depression that needed medication. I haven't experienced it in my practice. I haven't, but that said, I haven't had nitrous in my office for years and years and years just because you can scavenge, but I don't think you get it all, and I frankly don't want to be exposed to it. But Ben Lynch, www.seekinghealth.org, he's got a webinar where he specifically talks about the risks of nitrous oxide, and I think at a minimum it's something that we need to be aware of. In terms of genomic testing, it's cheap right now. You know, you can get your entire raw genome from 23andMe. It's a spit test. Patients can order it themselves. And then what you need to do is once you get your raw genome from 23andMe, there's a variety of sites. There's Genetic Genie. There's I particularly like mthfrsupport.com. Prometheus is another really good site. I'm trying to think. Nutricology, I think, is another one. Typically, I mean, Genetic Genie is a donation of $5. It's a voluntary donation of $5, and it will tell you. Particularly, there's two specific alleles that you're concerned about. There's an A1298 and a C677, and those are the two main alleles that they're worried about for methylation, and it'll tell you what your status is on that. You know, and it affects, when we talk about, and Chris, you talk about methylating factors in B vitamins, it really talks about, you know, should you, if you've got someone with the COMT, because you'll get, it's comethyltransferase, whether they should be taking hydroxycobalamin as opposed to methylcobalamin. I mean, I think I completely agree with you that this methylation and treating methylation and taking a lot of methylating cofactors is a real slippery slope, and I think we're just beginning to really understand it. I think that it's my latest rabbit hole, but I think it really has it's got a place in burning mouth. We've had patients that have been able to, I mean, burning mouth for months and months or years, where we've been able to either take them off methylcobalamin and switch them to hydroxy, or vice versa. And I know I'm off track there with respect to the depression, but yeah, and I'm sorry, I just can't speak to the pathways directly, but Ben's got it down. And it's something I sure never learned in dental school. Yeah.
I think it was on the site you mentioned.
Ben's site.
Where there were two case reports, one young child that was in a dental setting, I think, I read it, and then another that was in a medical setting. And I want to say they determined it was a bit concentration of nitrous administered, and then, of course, duration of administration. So there's a lot of factors that would...
Sure. I mean, that would make sense, you know, how
Sure.
compromised is the pathway and how much can it metabolize.
Yeah.
So I have a comment towards the methylation. I think we learned today from Dr. Oshner here that mercury compromises our methylation, and it's the nitric oxide that needs to be uncoupled with those of us that either have the MTHFR variant or have mercury that is compromising our methylation. And from what I've been watching with patients is that, I'm a dental hygienist, by the way, if you give all patients a little bit of B12 in the form of either hydroxycobalamin, which would reduce their nitric oxide levels prior to nitrous oxide administration, and accompanied with a small bit of folate, they seem to come out of the use of the nitric oxide much better. And that's only just right at their appointment. They don't need to do that the day before or after, but it seems to be a nice prophylaxis. Yes, sublingual, anywhere from 1 to 2,000 micrograms on your hydroxycobalamin. On a child, I'd go on the lesser. Seems to be doesn't matter. And then the folate, you only need 1,000 on a child or 2,000 micrograms. As hydroxycobalamin in a patient who has inflammation, because hydroxyl will mop up that extra nitric oxide made by the pathogens, methylcobalamin could be used in somebody with less likely inflammation.
Right. No, I said the folate is methylfolate.
Is it L5-methyl?
Or folinic acid for pregnancy and for some children. It just depends on what you know, how much you know about them, and how much you know about methylation is which I would choose.
If there are no more questions, we should all give the speakers a great big hang. Thank you very much.